Thank you. Well, hello, everyone. I'm Mandana Khalili, Professor of Medicine and Director of the UCSF Research Coordinating Center's Investigator Development Unit of the NIMH-D Multiple Chronic Diseases Consortium. I'd like to welcome you to our monthly training webinar. Before we start, we would like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place the land that UCSF sits upon their home. We're proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. Well, today we're honored to have Dr. Sara Landis speak to us about hybrid effectiveness implementation approaches. Dr. Landis is a psychologist and researcher at the Central Arkansas Veterans Healthcare System in Little Rock, Arkansas. She's the director of VA's Behavioral Health Quality Enhancement Research Initiative program. She's a co-director of VA's newly established Evidence Policy and Implementation Center and an associate professor at the University of Arkansas for Medical Sciences. She also serves as a core faculty of the UAMS Center for Implementation Research. Her research interests are in the implementation of evidence-based mental health interventions with a focus on suicide prevention and larger healthcare systems such as the VA. She has expertise in hybrid effectiveness implementation approaches, and she's received research funding from the VA Health Services Research and Development, the QUERI, the National Institute of Mental Health, and the Department of Defense. She's been the past professor of Society of Implementation Research Collaboration. And so we are truly honored to have her speak to us on this topic, and we really, really appreciate it. We also wanted to ensure that you submit your questions through the chat. I'll be monitoring the chat, and we will be sure to have some time at the end of the session to address questions as well. Dr. Landis, welcome, and we look forward to your presentation.
Thank you. Can y'all hear me okay?
Yes, we can.
Okay, awesome. Thank you. I'm going to get my slides up. And then while I do that, I'm going to make sure, I know you'd mentioned folks submitting questions via chat. Okay, there we go. I have the chat pulled up. It's actually not distracting to me if folks want to ask questions as they go. If you have something that you want me to clarify or a question, I might wait to answer it, or I might stop what we're doing so I can make sure I'm being clear. So feel free to use that as we go. And I also have a few not interactive slides. They're basic slides, but there's some questions on some of the slides, so it helps me know you all as an audience. All righty. So let me get started. So just to acknowledge my funding, so I'm funded by VA's QUERI, the South Central MIREC, and the Translational Research Institute, which is part of our NCATS group here at UAMS. And these views are mine. They don't reflect policy or position of the VA or the government. I'm coming to you from Little Rock, Arkansas. In case you don't know where Arkansas is, I moved here from San Francisco and had a vague idea of where Arkansas was. And I was a little wrong, to be quite honest. So this is where Arkansas is. Those are our buildings I work in. I'm actually at home. I haven't been in those buildings for quite some time, but it seemed a little creepy to put a picture of my house. So I'm coming to you from Little Rock, Arkansas. And I'm going to start actually with my contact information rather than put it at the end. I have both of my email addresses here. If there's questions, you'll notice we'll end the talk with me saying, let us know if you want some help. So there's my email addresses if you want assistance with hybrid designs or hybrid approaches. And there's my Twitter handle. And if you see me in person these days, I look more like this with the mask on. And if you come to Little Rock, we have some cool large art. So just a shout out for Little Rock, but there's my contact information. And also before we get into the meat of the presentation, I wanted to give a special shout out to my colleague and mentor, Jeff Curran. He wrote the original hybrid paper in 2012, and he and I have been working on this with a bunch of other awesome folks. And he gave me his master set of slides that I've adapted over the years. So I just wanted to acknowledge his work in this, and also he's also a pretty awesome mentor and researcher. So shout out to Jeff, who would hate, by the way, that I have his picture in these slides. All right, so today's topic, hybrid approaches, and I have, I think you'll have these slides. If not, I'm happy to make them shareable. I have hyperlinks built into them for all the papers I'm mentioning. So I mentioned Jeff's original paper in 2012, the hybrid implementation, effectiveness implementation hybrid designs. And then we had a recent paper in 2019 that talked more about hybrid approaches. And I keep saying design. So notice both of these titles say designs, and you'll see I have it lined out here in the title. We've been working really hard to talk about these more as hybrid approaches or hybrid studies, because hybrid studies can have all sorts of research designs, and we'll talk about that a little later. You may notice I slipped back into saying designs. So if unfortunately there's no way to like have a buzzer to buzz me every time I do that to punish me out of it. So we're going to talk about hybrid approaches. And this 2019 paper, I'll say it's nice. I wrote it, so I'm biased. We have a lot of examples. So if you want more detailed examples in one place about hybrid type 1, 2, and 3, it's a great place to go. And both of these are open access. But first, before we talk about hybrid approaches, I want to start with Jeff's paper. It's another one of my favorite papers, called Implementation Science Made Too Simple, a teaching tool. So Jeff uses really great language when we talk about implementation, and especially around hybrids. And it would be helpful for us to start with that language. So if you have questions about, am I a type 1, a type 2, a type 3, what the heck is a hybrid? This paper gives some nice language. And so when we talk about hybrids, some non-scientific language or some simple language can be really helpful, because sometimes folks get a little confused about what's effectiveness and what's implementation, and we sometimes not sure which piece we're talking about. And so we talk about hybrids, we think about the intervention, the practice, the innovation, whatever you want folks to get, right? A policy, a pill, a practice, all those different P's. Here in Little Rock and Jeff's group, we call that the thing. That's the thing you want to implement. So whatever your intervention is the thing. Really, really fancy language. And so effectiveness research looks at whether the thing works. Implementation research looks at how best to help people or places do the thing or get the thing into practice. And implementation strategies are the stuff we do to help people or places do the thing or get the thing into practice. And some of our main implementation outcomes are how much and how well they do the thing. And I can also tell you, this is helpful in figuring out hybrid types. It's also kind of helpful if you ever have to explain to your family members or your loved ones or your friends what the heck you do for a living. The thing language can be pretty helpful. So using that language, hybrid approaches look at both the thing and doing the thing or getting the thing into practice. And we have different types of hybrid approaches that tend to emphasize either effectiveness of the thing or implementation of the thing. So if folks would be willing, if you're not considering hybrids, maybe think of something that could be a hybrid study in your future. Is your work more focused on effectiveness of the thing, like does the thing work, implementation, or getting the thing into practice, or both in some way? If folks wouldn't be willing to put that in the chat, just to give me a sense of what folks are interested in. Or do we have a bunch of bench scientists? In which this case, this may be a little off. All right, so a lot of both. Okay, good. Thank goodness. Then we're in the right place for this talk if folks are at both. And also, just out of curiosity, if folks wouldn't mind entering, where are folks coming from? Because I know this is a coordinating center for a bunch of P50s. I'm curious where folks are joining us from. And I see Maria Fernandez, you're an author on one of our papers. I should just let you give the talk. I'll go relax. All right, so UCSF, Mayo Clinic, San Diego, UAMS, yay. Alabama, Awesome. Bay Area, Chicago. Cool. All right, awesome. It's a little more fun for me when we're not in person. Emory, so we have Emory's in Atlanta, I think. So it's just nice to know where folks are at. All right, so we have folks from all over, and most of you are interested in examining both, doing the thing and does the thing work. So I probably don't have to do as much work to convince you to consider hybrid approaches, probably also because you're here. You're probably interested. So part of it is maybe we can speed things up a little bit. So looking at effectiveness first and then implementation can be slow. And we really don't want to wait for perfect intervention effectiveness data before going to implementation research. So we have a way to kind of backfill effectiveness data while we also test evaluate implementation strategies. We also want to know, does the thing work? How does the thing work related to levels of adoption and fidelity, right? So if you've only implemented the thing halfway, does the thing still have an impact? So we wouldn't know that without information from both sides. So these are just some reasons to consider hybrid approaches. So the original paper in 2012 was really, and Jeff will be the first to say that he wasn't the first to have this idea. He was the first to put it in writing. Folks are thinking about how to combine these to speed things up to get things implemented more quickly. And you'll notice the 2012 paper is really clinically focused. All the folks in that paper were health services research and thinking about maybe evidence-based psychotherapy or different kinds of medications getting implemented. But this also seems to work for other types of interventions. So for example, for policy. So we have someone here, RVA, who's interested in implementation of policy. So how do you get policy implemented? And I know Marie is here. Some of our recent work has been working with her to think about how does this also look like for prevention work. So we can think about this not in a narrow focus of clinical or health services research, but you can implement all sorts of things, right? So you can think, how do we best implement psychotherapy, but also how do you best implement good housekeeping practices in your VA facility? You can implement all sorts of things. And the original paper focused on trials, but we're focused more now on just this hybrid idea with different research designs. So the hybrid approach is more about combining research questions rather than combining designs. You can use all sorts of research designs within hybrid approaches. And I have that underlined for me to remember. We're calling them hybrid approaches or hybrid studies instead of designs. So we have three types of hybrids, hybrid type 1, 2, and 3. And so we'll talk about these a little bit in depth. So the hybrid type 1, so here on this side of the screen, is focused more on effectiveness research. So it's more about testing the thing. So does the thing work? So for example, you might have an evidence-based practice that you know works in some settings or with some populations, and you don't know if it works in others. So you might be more focused on testing the thing, and you also want to observe or gather information on implementation or doing the thing while you're getting more effectiveness data. So that's a hybrid type 1. On the far other side, for implementation research, a hybrid type 3, the focus is on how do we get the thing into practice? Which implementation strategies work best? So we're comparing one implementation strategy against another. And then we might also still gather some effectiveness data on the thing. And then in the middle, we have the hybrid type 2, which is some combination. And I can tell you, we've had lots of conversations of, is it 50-50 that you're focused on effectiveness or implementation? Is it 60-40, 80-20? And for those of us who like those nice, clean distinctions, we don't have those for hybrid type 2. So it depends is really usually our best answer for hybrid type 2s. I'm pretty biased. Hybrid type 2s are my favorite. And I think for a lot of folks, it's their least favorite. So we'll spend some time talking about all three types and how they'll be useful. And we've also had lots of discussions about changing the typology. So making it, and we got really more in the weeds and complicated. And then we went back to hybrid type 1, 2, and 3. So far, I think we might be sticking with the type 1, 2, and 3. So this this visual is just literally the same thing as the previous slide. I've noticed some folks like it better in the table format and some like the figure better. So if you think about research aims, for hybrid type 1, again, the primary is the effectiveness of the thing. Type 3 is the impact of the implementation strategy. How well does your implementation strategy work? And we often say impact of the implementation strategy. You could say, is the implementation strategy effective? And that's where people get themselves really confused about whether they're talking about effectiveness or implementation. So we tend to say impact of the implementation strategy. And here in type 2, again, we have primary, and sometimes we call it secondary or co-primary aim. So you have both effectiveness and implementation. We're going to start with hybrid type 1. So again, the hybrid type 1 test the thing, the intervention or innovation, and explore implementation related factors. So there's been some arguments recently that folks shouldn't be doing standard effectiveness studies without doing a hybrid type 1. So we have the opportunity in doing effectiveness studies to gather this kind of information. So we think of this as an effectiveness trial or study plus, right? So you might describe the implementation experience, what worked or what didn't, what barriers or facilitators the implementation you saw. You might notice how the intervention needs to be adapted going forward. What's needed to support people or places to do the thing in the real world, right? So it might be moving from efficacy to effectiveness. You might be in a clinic and going, oh, you know, we had a thing that requires 94-minute sessions. Yeah, imagine that, but 94-minute sessions, and that doesn't fit in the real world. Surprise, surprise. Hopefully you would have already known that, but it might be you find something that there's something that doesn't quite work when you move into the real world setting. So when would you do a hybrid type 1? Some indications include if the clinical effectiveness evidence remains limited, right? So you really feel that you need more effectiveness data. So really focusing on implementation might be premature. However, effectiveness study conditions really give you the ideal opportunity to explore implementation issues. So you can find out things like, and I think this is on my next slide, I always forget. Okay, I always say all of this and then remember this slide is here, so I'm ahead of the game this time. All of effectiveness trials essentially use implementation strategies, right? We're all doing things to make sure our study works. All right, so if I decide, I'm a clinical psychologist, so if I decide to test a psychotherapy in an effectiveness trial, I'm going to probably pay the clinics or pay the clinicians or make sure I backfill my study therapist time so the clinic keeps running. I'll probably do fidelity checks. I'll probably want to make sure my therapists are doing the therapy so my study works. So all of those are ways to support implementation, and they're really resource intensive. So we're already doing some of those things to support implementation already. So part of a hybrid type 1 is maybe more formally or strategically documenting what you're learning as you're doing these things to support your effectiveness trial. So we can learn from these strategies, right? Maybe we find out, man, even if we pay folks, it doesn't work, or people aren't doing the therapy, right? Maybe we find out no one's reaching fidelity when they're doing it in a usual clinic. But these are all things that would be really helpful to know, both to understand our effectiveness data and to inform implementation. So I have here some examples of type 1. We are in the deep weeds of a scoping review of hybrid papers. There's a lot of protocol papers. So if you are interested in any type of type 1, type 2, or type 3, there are boatloads of papers for you to look at. And these are just some of my favorites in terms of, so I think all these, looks like all but one is a protocol paper. Megan Lane Falls is a really great one if you have folks who are in medical settings. She also tends to have really good study acronyms. You can see we have things on this one on top, looking at improving mood and weight in primary care, substance use clinics, insomnia. And I've noticed I'm the one who does all the lit searches for our scoping review. And as we've gone from 2012 to 2022, the settings and the interventions or things has just really exploded. So you can really find good examples of something that might be close to what you're interested in. And we, again, at the end, I'll say we'll help you if you need it. So if you say, I really need a implementation study in ICU with this problem, we can help you know if those exist already. So something for folks to consider or chime in the chat. How soon is too soon to start looking at implementation questions? I've seen some folks talking about, in our scoping review, I found one hybrid approach, but it was an efficacy implementation study. When do we think is too soon? Is efficacy too soon to look at implementation? Or is it not too soon? Do we want to make sure the thing we are developing can even fly in the real world? I wonder if folks have any thoughts about how soon is too soon to look at implementation questions? Or maybe just a yes, no, is efficacy too early for implementation? I see one not too early. I'm clearly biased as an implementation researcher and someone who likes hybrid. Not too yeah, but context should be considered. Right, I wouldn't say it's already there, formal, informal. I think part of this is, I sometimes think of the hybrid type 1 as whoever's leading that trial or doing that trial is paying attention to those things already. And it might be, it's a way to, I'll say, get credit for it, but also to more formally collect that information. Shana says, would we want to spend time and resources designing something that will never fly in the real world? I would vote no, which is why I think it's not a bad idea. I think getting us to think about, will these work in the real world before we spend all this time is really important. Okay, mindful of the time. So it's a hybrid type 1. Now we're going to jump all the way to the other side to a hybrid type 3. So hybrid type 3s test implementation strategies. Remember, implementation strategies are what we do to help people or places get the thing into practice. It might be things like education, facilitation, technical assistance, clinical reminders. And so the main focus is, does the implementation strategy work to get the thing into practice? And then we also observe or gather information on the thing or intervention outcomes. So again, largely focused on strategies, and the intervention outcomes are secondary. And oftentimes, those effectiveness or intervention outcomes are things that are already being collected. So often in, especially if I think of like psychotherapy studies or health services research, if they are testing implementation of an evidence-based practice, they may use effectiveness data that's already collected by the medical system, right? So if it's a therapy where they're collecting PHQ-9s already to assess depression, they may use that data that's in the medical record or service utilization data in the medical record, as opposed to doing primary data collection with patients. And often I say it tests an implementation strategy. Most implementation studies use more than one implementation strategy. So if I'm implementing a thing, I might use both training of providers and a clinical reminder and technical assistance. So it could also be testing an implementation strategy bundle or bundle of strategies. And so we have a note here that sometimes we proceed with implementation studies without a full portfolio of effectiveness studies. I work in the VA system, and oftentimes we have a promising practice that also makes good sense. And there's strong momentum to say we're rolling this out everywhere. So hybrid type 3 is a great design to say, let's test some implementation strategies if we're rolling this out everywhere. And also, if we still need some more effectiveness data, collect that while we're at it. That seems to happen a lot in big healthcare systems where there's a practice that seems to have good evidence, and there's a lot of pressure from multiple levels to implement it everywhere, so folks have access to something that could be helpful to them. And so a lot of the hybrid type 3 studies done in the VA have made good use of something that's getting rolled out already. Also, you might be interested, as I think I mentioned this a little bit earlier, how well does the thing work by level of or quality of implementation? There was a really great study, it's been a few years now, but for depression treatment, for cognitive therapy for depression, where the treatment fidelity or being really faithful to the treatment model didn't matter as much for outcomes, only if it were folks with moderate depression. For folks with severe depression, treatment fidelity really mattered for outcomes. So it would be helpful to, that's a good reason to still collect effectiveness data. If you're comparing implementation strategies, it's an opportunity to see how well does it work when it's implemented at different levels. So some considerations for type 3. Same things you would consider for any implementation trial. How much power do you have? Now we're starting to look at what's your evidence for the implementation strategies. We're starting to get implementation strategies that have an evidence base. What mechanisms of action of the strategies? How do you think this works? There's one of my colleagues here in Little Rock, Dr. Sonia Singh, is doing, she's proposing a study looking at implementation of policy, and she's using Heather Bullock's policy framework. I can't remember the name of Heather's framework, but it's Bullock is B-U-L-L-O-C-K, and it's a policy implementation framework. And it shows all these different levels that policy impacts as well. And I think it would work for just implementation in general. And so Sonia is thinking about what implementation strategies impact different levels, right? So if we think the barrier is at the system level, we need a system level implementation strategy. If we think it's at the provider level, it would be a provider focused or targeted implementation strategy. But really thinking about, there's lots of places things can go sideways when we're implementing interventions in large systems. So thinking about maybe where the barrier is, who needs targeted or what level needs targeted, and what implementation strategy makes sense. And thanks, Edwin. Edwin shared some different implementation strategies to consider. I like the carrots and sticks. I think that should be a formal name of an implementation strategy. We love PDSA cycles in the VA as well. And you also want to think about what's the cost of the strategies. So a lot of times in hybrid type 3s, you may consider cost, and it could be cost of implementation, cost of offering the thing once it's implemented, and different cost analyses. And then we'll come back to that a little bit at the end. And then if you think of the thing effectiveness data, the clinical outcomes, and really not clinical outcomes, you might not be doing clinical work. You want to think about, do you really need them? And you might think about what interventions do we not need to do a hybrid type 3 study for, right? You might have a thing that has so much effectiveness data that we don't need anymore. I think hybrid approaches are kind of the cool thing to do right now. So you might want to, if you're doing a hybrid type 3, you also want to consider, do I need to? Could I do an implementation trial and not do a hybrid? You really want to think about, are there measures available in existing data? Do you have to do primary data collection? Can you do secondary data collection? So for example, right now, one of the studies I'm doing, we're using available medical record data. So we're looking at service utilization. We're looking at different diagnoses, documented suicide attempts. So those are all things that we could say we have an idea that the thing works without having to do primary data collection with a whole lot of folks. So here are some type 3 examples. The ADEPT study there on the right, Amy Kilbourne's trial, is a really great type 3, but it's also a really great example of adaptive design in a hybrid study. Danny Almiral is a great adaptive trial person. So he's on that study. So that's a good example of both a hybrid type 3 that's adaptive design. I seem to have picked a couple. I think actually I picked all of the folks we know. I was a little biased in this group. So we have one here in the bottom right that was done here in Little Rock looking at CBT in rural VA clinics. We have our colleague in Arkansas, Taryn Swindle, doing a lot of hybrid designs, but in evidence-based obesity prevention in childcare. So how to do that in early childhood education centers. And that top left one with Mark Bauer, that's really a nice example of partnering with the health system leadership when a thing's being implemented to test implementation strategies. Before I go on, I'm going to pause and see. I should have paused after type 1, and I didn't. I got a little carried away. Do folks, before we move to type 2, do folks have questions about type 1 or type 3? Or general hybrid questions that would be helpful to answer now before we keep going? If you're new to implementation research, while folks are thinking, the Byron Powell has a 2015 paper that lists implementation strategies. And in that paper, additional file number 6, I think is the most useful document in that paper. I don't always look at additional files, but I have additional file 6 from that one saved on my desktop. It lists all the implementation strategies and gives you definitions of all of them. So if you're newer to implementation research, it's a great place to start. All right, I'll keep going, and if folks have questions or just comments, feel free to chime in. Okay, we had focusing mostly on effectiveness data in the type 1. On the other side, we had focusing mostly on implementation outcomes in type 3. And then in the middle, we have the hybrid type 2, which is some combination of some amount of both testing the thing and the implementation strategies to get the thing into practice. And it can look like, it could be either an implementation study of 2 strategies, right? So you have a dual randomized design. Brian Garner has several really great examples of dual randomized studies. He's really good at those, where you might be randomizing folks both. If it's recipient clinical, it could be. Thanks for that link to Byron's paper, that 2015 paper. So you might be randomizing to both implementation strategies. You might be randomizing your sites to an implementation strategy, and also randomizing people to the thing that's getting tested. Those dual randomized studies, there's not very many of them because I think they're quite the pain in the rear end to plan and pull off. There are a lot more of the single arm studies of one implementation strategy. So we're looking at maybe, we'll call it piloting an implementation strategy or bundle of implementation strategies and getting effectiveness data. So for example, I have a hybrid type 2 study right now in the VA, and we are looking at one implementation strategy at all of the sites and collecting additional effectiveness data because we needed more effectiveness data with a new population and setting. And we wanted to see if that implementation strategy works. So we had that second type for our hybrid type 2. I have this at the end, but in terms of thinking about, I can't remember, you all have a very long title of the series that I can't remember of the speaker series, but in terms of thinking about though, equity, I think hybrids are great study designs if you've noticed there's some sort of disparity in care or disparity in health or disparity in some sort of outcomes. So you may notice there's a disparity that one group isn't getting the thing, and so you don't have effectiveness data for that group. And you want to figure out how to get it implemented. A hybrid type 1 or type 2 might be a great way to figure out both effectiveness data and how to get the thing implemented. Or you might find that the thing needs adapted for a different population or setting. So you need more effectiveness data on the adapted version. So again, a hybrid one or two might be a great fit for testing that adapted version of whatever the thing is. So it's really, I think, a good study approach if you're interested in looking at how to improve equity or address disparities in care or health. So when we're thinking about a hybrid type 2, indications for a hybrid type 2, you have effectiveness data available. And as I said, maybe not for this context or population. You already know some barriers in facilitators implementation, and that might be formal or informal. So it might be, for my hybrid type 2, we didn't do a type 1 study first to get barriers and facilitators. We had some pilot funds and did a whole bunch of qualitative interviews to find out more on barriers and facilitators. Like, why aren't y'all using this thing? What gets in the way? What would help you? And then we use that qualitative data to inform our hybrid type 2. You might have, again, implementation momentum in terms of system or policy demands. The thing that we're implementing in my hybrid is a suicide prevention intervention that we also knew what was coming. We knew that there were plans to make it a mandate, so a policy mandate, that places were going to have to do this thing pretty soon. So we wanted to help figure out how do they help them implement the thing before it's mandated, so we can actually support folks in following the mandate. But those are some times that a hybrid type 2 would be a great fit. And again, I just want to highlight that data on barriers and facilitators doesn't have to be some big grant-funded study. I had, I think, like $20,000 from our healthcare system that helped pay for staff and compensation of time, and we were able to do a small project to gather that barriers and facilitators data. A lot of folks at our VA use, we have different pilot funds available, so they do some sort of pilot to collect qualitative data or quantitative data to figure out barriers and facilitators to implementation. And there's several, this is maybe a sidebar, there's several qualitative interview guide and codebook resources now available. So one of them is CFIR, which is the Consolidated Framework for Implementation Research, and it's at cfirguide.org. They have both qualitative interview questions and code books to help support you in using that framework. We've also developed one here in Little Rock for the IPARIS framework, the Integrated Promoting Action Research and Health Services framework for implementation. I don't think we have it on a website, but I'm happy to share it, where it also gives you a qualitative code book so you can use something that exists that aligns with the framework already and not have to recreate the wheel. So some more considerations for type 1. You really want to have an explicitly described implementation strategy that's thought to be plausible in the real world. So this is the clear distinction from type 1. In type 1, you're just getting information about barriers and facilitators, or what do we know about implementation. In type 2, you want a specific implementation strategy or bundle of implementation strategies that you're going to evaluate. You also want explicit measures of implementation outcomes. So that might be adoption. For my study, we're looking at, did a facility adopt the intervention? Have they implemented it? Are they offering it? Is each facility, what's their fidelity to the model? And for ours, we have 2 measures of fidelity that we can use. We can evaluate just in the medical record. Or if maybe it's psychotherapy, in terms of adoption. If you were implementing a new psychotherapy in a large health system, you want to know if one therapist is offering it, or are 50 therapists offering it. So you want to have implementation measurement. And if you want some help with implementation measurement, the REAIM framework is a great place to start. It's an evaluation framework, so it's reach, effect, and it really fits well with hybrids because it's reach, effectiveness, adoption, implementation, and maintenance. So for example, for our hybrid type 2, we look at adoption. Did the facility, are they offering it? But we also look at reach. What percentage of eligible veterans are getting the thing? right? So we consider it a success if they're offering, like our facility, when they implemented it, they're offering it to 89% of eligible veterans. So we were pretty pleased with that. So you want to have multiple measures to make sure that the thing's actually getting implemented. I've also noticed for REAIM, REAIM's really, it's a good fit with leadership. So all of our healthcare leadership here at VA and at the medical school, it's kind of the lingo they use already. And so I think it's direct and straightforward and really easy to communicate what you're interested in to leadership who aren't researchers. So you want to have some measurement for implementation. That always happens in a type 2. And you want to be clear about, and this is, if you ever come to Little Rock and you want to get us all like not arguing, but muttering and discussing something for a long time before we finally open, like to decide we need drinks, ask us about how you decide what's the intervention and what's the implementation strategy. You want to be clear about which is which. So the biggest thing that I've noticed in our scoping review is we have lots of studies that we're not sure if the delivery format of the thing is the thing, or is it the implementation strategy? And I actually think I give a different answer every time Jeff and I discuss it. So I'm clearly not convinced one way or the other. So you might have, so I'm sitting here on Zoom with you all, right? So I do therapy with patients. And so is telehealth part of my therapy? Is it an intervention component? Or is telehealth an implementation strategy to help implement the thing so I can deliver it to more folks? We have here the example of delivering the things over the phone. Is telephone-based something the thing, or is the telephone-based the implementation strategy? I'm sad to tell you that I don't actually have an answer for you. Yes. Like, and I think the thing that I think would be important if you're writing a grant proposal, or if you've done this already and you're writing it up in a manuscript, you just have to tell us. You have to decide for yours what you're saying. Like, you get to choose, right? You're saying I'm delivering this therapy and telehealth is the implementation strategy I'm using to help get the thing implemented. I know in reviewing grants, sometimes I disagree with what they've decided, but it's more, I care more about their clarity. Like, they've thought it through and they've decided, so I'm on board. So I think that's something, Amy saying it depends on how the thing was tested. I think so. I think that's sometimes what gets people in an argument about, well, was it always telehealth based? Then it's the thing. If it wasn't, maybe it's the implementation strategy, or have you adapted the thing to be telehealth? I feel like Jeff and I go round and round. And I think as long as you tell your reader what you think it is, that's what matters. And one thing I'll highlight, if you're thinking about writing grant proposals for hybrids or writing up a finished hybrid for papers, I think being really specific to say, this was our intervention, this was our implementation strategy. We did a hybrid type 2. And really saying what type it was to help your reader know what you were thinking. And Shana says, outline my thoughts about the consequences of assigning delivery format to one category or the other. I'm not sure I have a clear outline of my thoughts, to be honest. In doing the scoping review, I can tell you, I must be easily persuaded, because the papers who said clearly, this is the intervention and this is the strategy, I bought it. The ones where it wasn't clear was where I had the most trouble. And I think like that could, I think somebody needs to write a paper, like kind of writing that out, lining that out. When it says, you say, I'm from a slightly different framework that considers context as constitutive force interventions. Yeah, I think, totally, Shana, I think you should write that paper. I would read that paper. I think, I would totally read that paper. please write it. But I've noticed when I read these different papers that use it differently, I'm convinced both ways, different days and different times. So be clear in what you decide. I'm mindful of the time.
For me, it's,
so a couple things,
could I randomize the implementation strategy? Particularly when as you've mentioned, Sarah, around things around cost. If I have, could I do a reduced version of this implementation strategy while still doing the thing in the same effective way? So that's what leans me towards, what are the different implementation strategies? Yeah,
I agree. And I think if you also said the opposite, I'd probably be nodding also.
Yeah.
I'll be transparent that I would probably be agreeable to all of them, which I think frustrates me. You also want to think about, what if your implementation strategy leads to poor adoption or poor fidelity? Then your effectiveness data is compromised. So you want to think about how to deal with this. You want to use implementation strategies that have evidence that they work. You want to have measurement and plans to address poor adoption or fidelity. You want to have time to deal with this. I think that's Jeff's last line there on the bottom about anybody getting queasy over this. I think this is part of why folks find type 2 is a little mildly aversive. So here's some type 2 examples. There's Brian. So that's Brian Garner. Brian has some great dual randomized. So I knew I included one of those there. Given we only have about 10 minutes left, so I've actually revised these slides at 11:30 last night because one of our new papers came out at 11 p.m. about hybrids, and I wanted to include it. So I have here, if you need more support or tools. So I got to line out one thing that I now can offer you, because it is published. We're also working with Maria Fernandez, who's on the call, to build a web tool to help you select hybrid types, not hybrid designs. And Maria's just put a link there in the chat to the paper. So this was published today, technically. Apparently, I think they were multiple time zones ahead of me. So I thought it was yesterday, but it was, the date was today. So we have reflections on 10 years of effectiveness implementation hybrid studies. And so we have reflections across 5 areas. The big thing is to replace the term design in favor of study or approach. And we have some recommendations. Number 4 is recommendations on research designs that align with each hybrid study type. Hendricks Brown has a great paper talking about research designs it's a really great resource for picking a research design within a hybrid study. We have guidance on selecting a hybrid type that I'll show you in a moment. We critique the 1, 2, 3 typology. And then the paper ends with some thoughts about how to integrate cost analyses into hybrid studies. So figure 1 in the paper, so Jeff and I have been doing workshops for a while on hybrids, and this is figure 1. I'm not sure why they called it a figure when it's just text, but it gives you 4 questions to consider to figure out how do you select a hybrid. And so questions like, what's the nature of the effectiveness data of your intervention of interest? And so we have some answers. So if it's really strong and you don't need a lot of adaptation, you might consider a type 3 or a type 2. If you have mixed results or you don't have strong effectiveness data, consider a type 1 or 2. You'll notice it says consider one of these 2 of 3. So it's helping guide you. It's not giving you the final answer. How much do you expect the intervention will need to be adapted for where you want to use it? And then how much do you already know about implementation determinants for the intervention in your context of interest, right? So how much do you know about barriers and facilitators? How ready are you to evaluate real world implementation strategy or package of strategies? So that paper gives you those 4 questions to help guide you. And I added the bonus question that didn't make it into the paper. So in our workshops, this is the question that came at the end of the handout we used. After answering those questions, do you still want to consider a hybrid study? So we have no, and it says feel free to run screaming from the room. And yes, which I hope the answer is yes. right? Some suggestions, looking at published protocol papers and manuscripts, talk with people already funded to do this work. Implementation researchers are really, really collaborative. Talk with project officers, and you'll say it says, give us a call. So at UAMS, Jeff established a Center for Implementation Research. And then also at the VA, I run our behavioral health query program. And part of our duties are to offer consultation for free, which is nice. So if you are wanting to do a hybrid, or maybe you have a hybrid planned and you're thinking, oh man, I need help with this part of it, please reach out to us. We're happy to offer consultation. We do one-on-one consultations. We also have a monthly group meeting in our Center for Implementation Research, and we invite two folks a month to come to those for group consultation. And I will warn you, our group is rather enthusiastic and excitable. So if you want only a little bit of feedback, the group format's probably not your jam, because they get really excited. But you're welcome to use those resources. And again, I'd put my email above, so you're welcome to email me to utilize those resources. And I already talked about this a bit earlier in terms of equity and hybrids. You can look at equity and intervention or health outcomes, equitable delivery, right? Is it getting implemented the same in different settings? And you can target equity with implementation strategies. You can really think about, if you see a disparity in care, a hybrid study may help you get data that you need to address that disparity. We only have about 6 minutes, which isn't a whole lot of time. I want to stop here, though, to answer questions and to be respectful of the end time as well. So if folks have any questions, I'm going to put my email again in the chat. So if you want to make use of our consultation services, we're happy to have you. Ed?
Thank you so much, Sarah. It's always a special thrill to hear live from the people that you're always citing in your grants and your papers on this. So thank you so much. And thank you again for being so open to direct contact and assistance with people. I think it's so refreshing to see that level of collegiality. Thank you so much. I just had a brief question. It's around, like, any thoughts on issues of the implementation and control comparison conditions and type 2s and 3s, randomized, using historical, strategy dose, those sorts of things, quasi-experimental things, like, what now that you've been doing your scoping review, what have you seen around there, and what are kind of your favorites? You hate to waste resources and not provide your best foot forward, but randomization and comparison control is still gold standard.
Yeah, that's a good question. So a lot of my work's been done in the VA, in the national healthcare system, and a lot of our work with Query is program evaluation. So it's not, I'll call it capital R research. So we are working with operations folks to evaluate whatever they're implementing, or to help them implement the thing they've decided needs implemented. And we often have to do some finagling, I'll say, for randomization, right? And I think part of it is, if we're implementing something in a healthcare system, we want everybody to get the thing. We want everybody to get the implementation strategy. So some of my favorites are using a stepped wedge design, where you're randomizing people to start, like when they start. So that way you don't have, right? So if I'm thinking about some of our participating facilities in my study, I don't want the folks in Wyoming at the one medical center, VA medical center in Wyoming, to get randomized to not get the thing or not get the implementation strategy. So I think a stepped wedge, if we think in terms of making sure everybody gets it and having some amount of randomization or comparison, is really helpful. The adaptive, so the SMART designs are really great. I think they're both complicated and not. I think sometimes I think they're really, when Danny Almiral explains them, I think they make sense. And then when I try to explain them, it doesn't. But really thinking about, so the adaptive design, so you get to a time point where maybe you're comparing technical assistance to facilitation. So technical assistance is, lighter lift than facilitation, so less resource intensive. So you might have a time point where you look at if a site is doing well, they just keep going with what they have. If they're not doing well, they get randomized either to getting what they're getting or getting facilitation. And there's multiple time points, so they have multiple opportunities to get more assistance. And also those designs that also say we're not using resources we don't need to use for sites that are like, I got it, we're doing well, like get out of our way, we're doing great with what we're getting. So I think those are designs, those studies I really like. So I know on the examples I gave, Amy Kilborn's ADEPT was one of the adaptive designs. She actually has another one that's an adaptive design that I can't remember the name of the trial, but they're both really good examples of adaptive design.
Thank you, Dr. Landis. I wanted to make sure we asked this question off of you with regards to the NIH institutes or centers that are more interested in funding hybrid approaches than others. Any suggestions?
Yeah, I'll say short answer is yes. I think some of the institutes are requiring hybrid type 1s if you're doing an effectiveness trial. I know Jeff and I are on one that was that they submitted it as a randomized controlled trial, and they were told if they revise it to a type 1, they would be funded. So I think hybrids are, I think people don't want to wait. I think people are eager to get people better care, better outcomes, and don't want to wait. So I think hybrid type 1s are an easy sell. I also think though, if you're in the implementation section, study section of NIMH, you don't need to do a hybrid type 3 if it's not needed. So I think I'd push yes on the 1 and then maybe question if you need it on a hybrid 3. So I do think folks are really interested in that.
Great. And I think we have one other question with regards to would it bias effectiveness if you assign a higher weight to treatment arms with better implementation?
Oh, sorry, I have an alarm going off in my ear on my phone. I'm sorry. I'm not sure. I'm also nowhere at times. Like if you want to email me that question so I don't stumble and say something that doesn't make sense, I'd be happy to answer it over email. But I also really appreciate folks being interactive. It makes it more fun for me. So I really appreciate that. And thanks for having me.
Thank you, Dr. Landis, for that outstanding presentation. And we'll be sure to connect with you through email as well. Thank you again.